Welcome to the next episode of the Many Minds podcast, where our goal is to encourage collaborative community healthcare using many minds for better outcomes. We want to understand what makes your specialty special and how we can support you to provide better care for your patients. I'm Alex Davis, physician assistant, along with Tyler Murray, nurse practitioner.
General disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We're just here to learn from each other and have a good time.
Today we get the privilege of having Jennica van Blerkom with us, who is a PA, a fellow Rocky Mountain alumni, and she works in allergy, asthma, and immunology.
Oh, yeah. I'm glad you said it, not me. I clearly could not have gotten that one.
You get the next one.
Thank you. Jennica, thanks for coming on the show today.
Yeah, I appreciate it.
You know, I think to start us off, why don't you just tell us a little bit about your background and currently your practice and what that looks like. Get us to understand what it is that you do.
Yeah. So I'm a PA and I work for Intermountain in allergy, asthma, and immunology. I attended Rocky Mountain. I graduated in 2019. Prior to that, I had worked as an MA in chronic pain, decided I didn't love that, but it's still interested in medicine. And I think actually coming out of PA school, I didn't really know what I wanted to do. I think you have this huge network of information and so much stuffed into your head knowledge-wise, but where did I want to go with that? I thought maybe family practice, maybe women's health, women peds. It was right prior to COVID-19 and stuff, and I applied to a lot of jobs. I probably applied to 70 jobs, given I was also 7 months pregnant, so maybe I wasn't the most hireable state of my life. But anyways, but I kind of thought I do really want to work for Intermountain. I had super good experience with my rotations, and so I was leaning there, and they posted a job for actually internal medicine, and I was like, ugh, that's probably my least favorite rotation, but I'll apply. And then they're like, actually, we posted wrong. It's for an allergy clinic. And I was like, oh, that's actually pretty interesting to me. My little sister had a milk allergy. My family has allergies, pet allergies, all those kind of things, asthma. And that's my first job at a PA school, and I've stayed there, been there about 5 years, and absolutely love it.
Oh, that's awesome.
So that's been the first job out of school.
Yeah, and
so
I've
dove right into a specialty.
Yes, that was not the plan, but it's also hard to kind of think about leaving because I love my job so much.
So you said early on, though, chronic pain. What was your role in that capacity?
A medical assistant.
Medical assistant.
Kind of for my hours prior to PA school.
Oh, nice. Yeah. And was that an independent practice, or was that?
Yes, it was actually down in Orem. It was called Utah Valley Pain Management back then.
Yeah,
and they've actually been
them.
acquired. Oh, of course. Yes.
By Intermountain.
They've been acquired by Intermountain now.
Yeah.
But a lot of the same PAs and physicians still work there.
Yep.
Oh, small
Good clinic.
world.
Yeah, they do a good job.
Yeah.
We send a lot of our EMG studies over to Dr. Oki.
Yes.
Yeah, so
love him. No, I love the people I work with, but it's a hard specialty.
It is.
Yeah. It is tricky.
Yeah.
And you were mentioning earlier before we even started that the idea of a PA or physician assistant, physician associate was a whole new thing to you because where you come from, that wasn't a thing.
Yeah. So in Canada, I had never heard of a PA. Nurse practitioners have a little bit more traction than PAs. They're kind of like here. It's a little bit of an older profession, but really I don't think I'd heard of a nurse practitioner either. So when I came down to school, I was like, I don't want to be a nurse. I really don't think I'm interested in MD. I don't know what I want to do. And I had a friend come up to me. I still remember where I was on campus and I'm going to PA school. And I was like, what is that? Mm-hmm. And I was like, yes, that is exactly what I want to do. And from then on, I knew it.
Committed.
Yep.
Love it. So I don't feel like there's a lot of providers in your space.
No,
it's a very niche specialty.
It's a small little field, yes. And you don't really go into allergy in PA school. It's
right.
It's a
it's
small
not one of the
little
topics that's
field.
really heavily covered. You don't have this 6 weeks in-depth course covering that kind of thing. So if there's not a ton of the providers in the area, what's your workload like? Are you guys getting overwhelmed because of the demand or?
Yeah, allergy. Yeah, I think allergy is really busy. I know, I'm trying to think of how many there are in Intermountain, but it's up from Logan all the way to St. George. I want to say there's I think 8 of us, maybe 9. Two, I guess whatever, how you want to say it, a nurse practitioner, 1 PA, the rest are MDs. So it's a really small little field, but, and yeah, we're busy, especially when it hits allergy season, May, people are like, wait, I'm miserable. So.
Yeah. I got it a week ago. just been killing me.
Probably the grass.
Yeah. What's your patient population like then? Who are you working with?
I remember when I went to interview for the job, because again, I thought I was going to an internal medicine position. I was like, tell me about allergy. And I think one of the reasons I love it so much is I get to see ped patients all the way to, patients in their 90s. So I have a great spread, probably I would say 40% pediatric. We see a lot of pediatric population, asthma, food allergies, things like that. So I have a huge array of patient population I get to see. They're very I feel like a pretty friendly client, patient population. I don't know. I just think I really have the best patients ever. And so, that's probably about a mix. I see about 14-ish patients a day. Allergy appointments take a long time. So typically how my schedule is kind of laid out is I'll see a new and then a follow-up in between and the new and then a follow-up in between. And because the news are there, a lot of people aren't expecting it, but you're there for an hour to an hour and a half for your appointment by the time you kind of get through all of your testing and things. So
interesting.
They kind of take up a room for a long time. So we don't have a huge quick turnover.
Gotcha.
Yeah.
What does testing look like?
That's what I was going to ask.
Yeah.
What kind of things are we going through?
Yeah. All of our patients are recommended to come in off antihistamines, because in order to do our testing, you should really be off for 5 days. Because it can block the histamine response of our test. So typical skin prick testing is, we have these little allergy sticks, and we buy these pre-made little vials from these allergy producers. I think Greer is a big company anyways, and we'll just have dog or cat or Timothy grass or box elder tree, right? And we just do a little dip in there and we scratch their skin, and we're just doing kind of a little topical scratch, just barely the first level of the skin.
Yeah.
It's on there for about 15 minutes, and then we get a response, and a little wheel and flare comes up, and we kind of measure the wheel and we measure the flare to kind of find out, is this an allergy? Food allergy testing is the same kind of way. So we've got all kinds of foods that we can test for. And then there's, it's all itchy and then it kind of calms down. We wash it all off. It's not as bad as it looks. There's not needles. People are usually pretty nervous, but we do it on babies. We do it on all patient ages. And then there's, asthma testing where we can get into spirometries or PFTs. And then we do a patch testing, which is more of a contact term. And so, different type of testing depending on what the patient complaint is.
What's the most unique allergy that you've seen? What's something that never is going to be seen again in your clinic?
Oh, that's a good question. I think food allergies are actually just not as darn common as people think. So they're
really?
I come in there and they're I think I'm allergic to
all of it.
I don't know, celery or a potato or corn or, and it's really the likelihood of you being allergic past those kind of 8 common foods, nuts, fish, milk, egg, even soy, wheat, we rarely see it. So I think a lot of people coming in thinking they've got a lot of these allergies, but it's kind of our job to truly teach them what is an allergy, what is the definition of an IG-mediated allergy, what this look like. We're talking an EpiPen, we're talking you can't even have contact with it, versus I think that's a major misconception in medicine. We use this term allergy so lightly, but if you are lactose intolerant, you do not have a milk allergy, right? Yeah. That is a completely different scenario. It's a completely different process going on, and that does not show up on our testing. So it's always kind of unfortunate when a patient comes in, or maybe they've even been referred by somebody and they're I just want an entire food panel because I get bloating or constipation or diarrhea and my stomach's upset. What kind of allergies do I have? And that's really not the right avenue to find your true allergy. I'm trying to think of something really rare.
The one that I see a lot on our patient charts or talking to people, and I feel like it cannot be real. Somebody they have it listed as an allergy to NSAIDs or ibuprofen.
Okay.
And to antihistamines. And I feel or to steroids. I was these are things you treat allergies with. How are you allergic to the treatment?
You are totally right. I don't, I potentially, could there be something in the compound or a topical that you could have a reaction to? Is it IgE mediated? Probably not, because there's other forms of your immune system not being happy with that. But is it truly an allergy in what we think of a type 1?
How about
NSAIDs is actually interesting though, because that is real. Yeah,
really,
that is a pretty real ibuprofen, aspirin, naproxen. So really common to cause a hive, lip swelling, and potentially even an anaphylaxis. And we see that a fair amount. And in fact, if someone comes in with a story that sounds pretty likely to be anaphylaxis, we're pretty, like, there's not testing to do for medications, really. There's some amoxicillin testing that is pretty well validated, but outside of that, medication is not typically IgE mediated, but we do think there is a type of IgE mediated of NSAIDs. Again, there's other things that could be going on, but that's pretty likely, actually.
Interesting. What about implanted hardware? That's another one that people ask commonly.
That was the one I was going to get.
The
that's
vessel
a really good
clips
question,
or
too.
the orthopedic titanium, and our spine cases use a bunch of titanium.
I mean, again, like, your body can decide at any time it doesn't like it and create antibodies against that thing. I also think the likelihood of that happening is a lot less common than maybe is put on charts, right?
Yeah.
So a lot of patients before they get surgery, if they have some kind of potential metal allergy or something, they'll get sent to us for patch testing. And that's where we put, that's for the more of the contact dermatitis. So we have like a metal specific patch series. We test all the different metals like cobalt and nickel and all the things. And if that's negative, we kind of say, like, this is the best testing we can do. We can obviously guarantee that your body won't like it, but kind of that, like, I don't know, those like hips that won't heal, or I don't know if we really can say that's truly an allergy to the component. So we can do patch testing if it's positive. Obviously, we kind of think, is there a different kind of implant you could put in? But again, I think, I wish I knew the numbers. I don't. But, like, for example, amoxicillin, only 5% of people who are listed with amoxicillin allergy truly are. And I can't say
I've
to what
read
it
that,
is with metal, but, like, I think people can say I'm allergic, and I wish there was maybe more of a, I don't know, history that went into this, like in medicine, but I think it just gets added to the allergy list, right? So more than diagnosing allergies, in allergy, I feel like we are delabeling a lot of the time. Like, hey, let's put these foods back in your diet. Let's take this. Let's see if you can have amoxicillin. So
that's a super common one. And then there's always the alerts on a patient's chart with cross-sensitivity to the cephalosporins, which is common in surgical procedures, which it's rare that it's a true allergy to amoxicillin. And then it's also rare that they're going to have the cross-sensitivity as well.
Exactly.
The one that we do see all the time is with the adhesives and the glue. Have you seen much of that?
Yeah, and it's funny because, again, our patch testing, like, we have, like, our North American 80 is probably our most extensive patches where it's like preservatives and scents and metals and things like bacitracin, like things that people can be allergic to. And a lot of time the whole patch series will come back negative, but people will have rash to the adhesive, like and that's irritant. Again, it's not necessarily like the type 4 delayed hypersensitivity where we truly just say this is an allergic contact dermatitis.
This is mind-blowing because you've just spoke on this for the last couple minutes, and it's just dawned on me. It's like this idea of a true allergy versus, what would you call it? I mean, what would we label it as?
It's kind of a tricky scenario, and I feel like a lot of my job is like this gentle education because people are like, no,
they've identified with that for a long time.
Like, I've been on Zyrtec for my whole life. This is what this is. Hypersensitivity, irritant reaction, like especially with foods, a food intolerance, it doesn't mean that they're not having symptoms from this thing. Is it fall into our true classification of what an allergy is?
Sure.
And when we're talking IgE-mediated allergy, we're talking that IgE, our little immunoglobulin E, our allergy version, that has decided it didn't like something, right? Like grass or peanut, and created an antibody against it. And within quick exposure to the thing, like usually minutes, right? If we're thinking about a peanut or milk or egg, your body creates a huge release of histamine, and that's what anaphylaxis is, like multiple systems in your body, releasing histamine at the same time, because it'll come and hooks onto your allergy or your mast cell cross-links, opens up, spills out histamine, which causes this response. So when you explain it to someone like that, they're like, oh yeah, I don't have food allergies, right? So
that's a way different beast. My mind is blown right now. I'm processing all of this as it stands.
Well, like drug reactions are just so hard, right? Because we can call it like, like lots of antibiotics cause nausea and diarrhea. Is that an allergy? No. Does it get listed as an allergy? Yeah, but that's more of a side effect, right? Is it life-threatening? Rashes are super common. There's like scary rashes like Stevens-Johnson syndrome, right? Where they can still be scary, but is that an allergy? No. There's serum sickness, right? There's like so many other things that aren't truly like, how would you treat this? Would you treat it with an EpiPen kind of thing?
Sure. What kind of treatments are you using then in your clinic? How are you helping these people when you identify true allergies? What does the treatment course look like typically?
Okay, so I mean, true allergies, there's lots of different things you'd be allergic to. Like one of the main thing I think people come to us is like they have poorly controlled seasonal allergies, right? And so if we identify those, and
especially in this area where we're at,
totally
geographically, it's seasonal.
Pollen's flying everywhere,
yeah.
tons of pollen seasons, yes. So, antihistamines are first line, nasal sprays like Nasacort or Flonase, eye drops like Pataday or Zatador. Like those are kind of our over-the-counter treatment for allergies. And if those are failing, we're usually thinking about immunotherapy or allergy shots, allergy immunotherapy. So that is, putting all the little allergens that we've tested you to in a vial and then giving it back to the person in a shot form. And kind of building them up. We usually start like a 1 to 1,000 and you kind of slowly build them up to reduce risk of reaction to help desensitize their immune systems. And that's like a 3 to 5 year process.
Oh my goodness.
It's lengthy, but it's also like really successful, like usually about an 80-90% decrease in symptoms. So,
because obviously there's levels of severity as far as somebody's allergic response, right?
Right.
So there are people that
can't mow their lawn, they can't go camping, they can't go trail running. Like, I mean, give me pretty
shuts
miserable.
them down.
Like I'm fatigued all summer, I can't roll down my windows. So it actually, like, I had allergies growing up and I would have never thought about going to see an allergist. Like, I'm like, oh, everyone has allergies. But then you see it in clinic and you're like, these people's lives are like, they're not living their full quality of life. And then you put them on allergy shots and they're like, I could be the poster child. This has changed my life. So it's really cool. And that's another reason why I like allergy is we have treatments that work. Sure. And people come out feeling better,
I think in most areas of medicine, people would be willing to take on an 80 or 90% success rate.
Yeah. I mean, that's a pretty good success rate.
That's pretty good.
Yeah.
I have to admit, I had a nurse that grabbed me when I was doing an OR day, and he was telling me about his seasonal allergies, and he's like, hey, my primary care gives me a Kenalog shot every year. He's like, he was planning on coming to see me. He's like, hey, could you give me one? So I was like, sure. I had no idea really what I was like, is that the right treatment option? Yeah,
Kenalog has really fallen out of favor. I feel like it was a more popular option, I don't know, like 20 to 50 years ago. I don't know exactly, but I think because we have better options, like we just know how long Kenalog sticks around and all the different side effects that come along with it. Like I don't think, at least in Intermountain or in the allergy world that I'm in, I know of anybody who will even do a Kenalog shot anymore.
Really?
That's
yeah, and I will have people especially come from like really rural communities and they're like, please can I have my Kenalog shot? But they've had them like the past 5 years and they might get like 6 or 8 weeks of relief, which might get them through it, but none of that's like curative, none of that. Right. And then the side effect profile that comes with an injection of Kenalog. Not ideal. I mean, does it happen? For sure. But
it's good to know, though.
Ideal.
Yeah, and it's probably just readily available in the primary care setting.
Yeah.
Anybody in the primary care world is comfortable and familiar with an easy Kenalog shot in the shoulder or something like that, and if they can help somebody, it's offered, I guess.
It's offered, yeah.
Which is great.
But in allergy, no, that's not really a typical
My mind then turns to the finances of this. So if somebody's committing to a 3 to 5 year treatment plan, is that generally covered and accepted under most insurance plans? Or what does that look like for the patient?
Obviously, insurance plans, you can't predict what they will cover or what everyone's plans are. But in general, I would say allergy shots are pretty well covered. If you have a high deductible and you're paying until you meet your deductible, then like, I don't know. I don't have my little info sheet. And obviously every allergy clinic charges slightly different, but I would say maybe $1,500-ish would be about a year cost of allergy shots if you were paying for it all either deductible or without insurance. And then there's usually like a really small fee per shot when they come in, and they're coming in like weekly, and when you first come in to kind of do that build up, and then you kind of move to like a once a month type thing. And
I was going to ask the frequency too.
Yeah, it's a really big commitment.
It is.
But I'm also shocked how many people, like by the time they come see allergy, they're like, they've tried Zyrtec, right? Like they've tried Benadryl or whatever and nasal spray, so they're like, I need something more. So I don't know, we put a lot of people on allergy shots.
Yeah. How about the patient that's getting the rebound from Afrin? Do you get a fair amount of that?
Yes, a lot of that as well. Like, why are you having these symptoms? And they're like, what is it that I'm allergic to? And their testing come back negative. And it's like, oh, you're just having rebound symptoms from your Afrin. You can't take this anymore. Yeah.
Is there a weaning process on that? Do you help them through that?
That stuff is a miracle drug. I will tell you.
It's so
my
good.
Goodness.
Don't use it for more than 3 days.
No more than 3 days. Exactly.
Yeah.
And I remember a patient brought it in and I looked at the back and it's like in the smallest, teeniest, tiniest writing, like, do not use for more than 3 days. And I'm like, why is this stuff like not prescription or just like better, I don't know, marketing or letting people know, like, it's great, but no more than 3 days. So yeah, we, one of the best, I think, suggestions I heard from one of my colleagues I work with is to fill up your Afrin with like saline. And so you can continue using it, but the more you use it, the more you're diluting it. So you're kind of tapering off yourself with the bottle. So it gets less and less potent. Yeah. I mean, steroids have been used if you need it, like a prednisone taper or something like that. But
is this still super common to see these types of patients coming in?
Yeah. I mean, I'm trying to think of like how often I see them. I mean, I probably see a version of somebody on Afrin who's, I don't know, once every other month, maybe.
It's interesting.
Yeah. A lot of people don't know.
Who's the best patient to refer to you then? If we see somebody in our world, what's like the ideal setting where we say, you know what, you should probably go see Jennica and chat about something?
Yeah.
Who should we be sending your way?
I think probably like somebody who is poorly controlled with seasonal allergies, and then especially if they've got other atopic conditions going on, eczema, asthma, eosinophilic esophagitis, hives. I mean, there's so many different components of other things going on. Obviously, just the typical seasonal allergy patient we're able to help, but all those little atopic conditions together, I feel like we're a really good spot for that and have some really great medicines, especially some of the new biologics that have come out are like incredible for treating atopic conditions. Then food allergy patients.
Where's your clinic at?
So actually there is a Lehigh clinic here, Dr. Abbott, here in Lehigh, and he is awesome. But my clinic is in downtown Salt Lake. So on like 4th and 9th, kind of past the U of U stadium. Are you your own, is it like its own independent building or? No, it's in a medical specialties clinic. So we've got most specialties in there. And then I work with my colleague, Dr. Silgi, is like the MD, and then just me. So we have our office of just 2. And I think all the rest of the allergy offices have just about usually 1 provider. So yeah, we usually can get people in a little bit quicker because there's 2 of us, but lots of allergists are booked out.
I was going to say, the way you're describing things, it sounds like you have quite a bit of autonomy. Like, how much are you actually collaborating with the physician?
Yeah, I feel really, really lucky because when I got hired by Intermountain, like I just felt like I had a fantastic onboarding experience where like the physician, again, like just like took me under his wing. His name was Dr. Bittner. He's retired now, and was like, let's do little lunchtime like seminars. Like he had little PowerPoints and he just kind of walked me through, and then I shadowed for a really long time. And then when I felt comfortable, I just started getting like 1 patient an hour, right? Just like slow, really. And I had no pressure on like the speed of how I started contributing. It was really quite amazing. I remember telling someone like, I've never felt stressed 1 day at work. And they were like, what? I'm like, yeah, like even as a brand new PA, because I always felt like I could ask. And there was just that relationship of like, if I didn't know, I would just run it past him until we could kind of build trust. I still run by patients if I'm just like, am I missing anything? Is there something else that I should be ordering here? Or am I doing the right thing? Probably, I don't even know if it's once a week, but maybe every other week or something like that. Because I think that's what really makes a really good PA or APP or first practitioner is when, you do the medicine that you feel confident in, but if there's something that you feel like you need to, is just a little bit out of your scope, or you just want to run by, that you have that ability to have that relationship where you can run it by. And a lot of the time it's those immunology cases because they're a little bit more complicated. But even food allergies with like little teeny kids, you're like, am I doing the right thing by offering a challenge to this person? This is like a baby, or it's a 15-month-old. So I love feeling like I can have that relationship. But in general, yes, I have like a ton of autonomy, and I have my own patient panel, and things just kind of run smoothly unless I need to.
How many patients a day do you see on average?
So about like 14-ish.
About 14.
Yeah.
And you're working 5 days a week?
4 days a week.
4 days.
Yeah.
Good for you.
So it's a pretty good specialty.
Really good. Yeah.
Kind of feel like I heard there say like someone else say like I have a unicorn job. I'm like, I kind of feel like I have a unicorn job too. It's like so good.
There's
so
probably
good.
Not much required on the weekends.
No
probably
call.
Not of emergency call.
No emergency
things
really.
like that.
Your patients are generally like pretty well.
Yeah.
They're not really sick if they're worrying about their allergies.
Sure,
I mean, not always.
True. That's true.
But
or
like
they're just not coming to your doorstep too. Like they're going to go to their other specialists.
Right. Or if you're really having an asthma flare, like yes, we'll see that. We do see anaphylaxis, but like even those often will be taken care of like at an urgent care off of weekends or something. On honestly, it's just kind of the best, and I love allergies.
That's
just
awesome.
So much. Yeah.
How about the compensation with that specialty?
So I think Intermountain is like pretty, well, they're at least trying to standardize, but I think in general they are pretty standardized.
Yeah. So this is a big corporation, a big hospital system that you work for.
Right. And so like when I tried to do my negotiating skills out of RMU when I first got mine, they're like, nah, this is what new grads start with. And you're like, dang it.
Yeah.
And I am not RVU based at all. And I don't think very many APPs are left at Intermountain being RVU based. Right. Potentially some derm, but they've really tried to kind of move away from that. I've been able to advocate just because I am pretty busy. I think we have I think our allergy is a kind of a higher producing specialty, or I don't know, but they keep telling me I'm billing okay.
An hour and a half appointments, you can bill as a 205.
I'm sure.
Oh, actually, I don't bill 05s that often.
Oh, really?
Because you have to be like physically in the room.
Oh, I see.
Where if like the nurse is doing testing, something, I don't know. Maybe I'm doing it wrong. No, a lot of 04s, but.
Okay. If you now have been in the game for, what did we say, about 5 years then? Mm-hmm. Any kind of special advice you'd give to others in the field of medicine?
Oh, in the field of medicine.
Yeah, with PAs and nurse practitioners. It sounds like you've gotten to a good scenario.
Yeah, I think just knowing if you're not happy in your specialty, like jump around, like look for something else, because there's so many little niche opportunities that you might not even have learned in school, or or just like making it work for yourself, because I think you do have that expertise that people are willing to keep, or they hopefully should want to keep the providers once they've had them trained in things. And there's a lot of side gigs out there too. Like I don't know if moonlight's the right word, but I actually work for the University of Utah too. And I do allergy nights there. So twice a week I go to the University of Utah and watch over their allergy shot clinic. So I'm able to have another little side gig. So I think there's things that you can do to kind of help augment your salary. And then as far as, I think rotations are really important in networking, and I think networking never stops, right? Just like looking around and asking and seeing what people do. So I don't know if that's any special advice, but
that's perfect. What else you got?
Well, I've got nothing else, my guy.
I was waiting for something profound to come out of there.
I wish I had something profound to say. I've just been soaking it all in. You guys have been doing great.
I know.
Going back and forth, and I've just been a witness to all of this, and I love it. So
can you tell I'm passionate about allergy?
I love it.
I seriously love it so much.
I love it. And that's what we like to see, is people that are actually really passionate and have some personal experience in their specialty. How about what's kind of new and exciting, or what should other providers and other specialties know about what you do? What's kind of the cool new things coming down the pipeline? Okay,
so I kind of mentioned the biologics. There's like some like Dupixent or Xolair. I don't know if you've heard of any of these medications. Omalizumab, Dupilumab, anyways.
Yeah.
Fasenra, Nucala. They are really amazing at treating several different atopic conditions. So again, like EOE, nasal polyps, food allergy. Actually, Xolair got approval for that. But that's not as what I'm excited about talking about. So there's those. Those are kind of new. I feel like that's really changing the face of allergy. But something that we do in our clinic is called oral immunotherapy, and that's for kids with food allergies. And I don't feel like tons of allergists do it because it's newer. And so I don't feel like the general public knows about it. So if you have a child, or potentially an adult, but usually young children are kind of who are our main patients, who has a severe true food allergy, like to a peanut or to a tree nut or to milk or to egg, something like that, we can actually do desensitization into the office. Now, this is not for every patient. There's always some risks associated, but in general, in like 2020, the FDA approved something called Palforzia, which was just a peanut powder. And they did like a study of, if I give this kid a small dose, they do it every day at home, they come back to the clinic, they updose, and we can actually desensitize them. And we typically aim for about 2 nuts. And so over like 12 to 18 week, maybe 12 to 18 visits, I would say, we can move them from not being able to tolerate anything to be able to eating actually their allergen. And it is not curative, at least we don't know studies wise yet, but we are able to desensitize. So for a lot of parents, especially who, they're sending their child to daycare for the first time or preschool, where they feel like they've had all the control of what goes in their kid's mouth, and then you kind of have to let them out into the world. this allows for them to have a bite of a cookie or a granola bar or something like that without likely having an allergic reaction because their body has built up that tolerance. And I just love peds patients, and I love food allergies. And so those are some of my favorite patients to see.
Probably the most rewarding because you probably changed lives, like the parents, their anxiety levels have decreased. You're seeing a change, and maybe the child doesn't realize it right then and there.
But they're like pretty happy to usually eat a Reese's Pieces.
Exactly,
yeah,
exactly.
And they're like, I love my allergy appointments. Eat
I
my
can eat
Reese's
this.
Pieces.
That is the best
No
doctor's
consequence.
appointment.
Yeah, we're a fun clinic.
Love that.
I have had patients who are adults. They're a lot harder to do, probably because their immune systems aren't as, changeable as an adult, but also because there's so much food anxiety involved. In fact, I've even had patients travel from like out of state to come to do it, as maybe their local allergist doesn't do it. But when you kind of hit like 9, 10, 11, 12, even like 15, and you've been told you can never eat this your whole life, and now we're saying like have some peanut milk or whatever, however we decide to desensitize it, like it is so scary, right?
Yeah.
If their mouth feels funny, and then you're trying to decipher, are these true allergic symptoms, are these
The
anxiety
psychological
symptoms?
effect.
Yeah, so it's, if we can do it when they're young, I feel like it typically goes a little bit more smooth, but I don't know. I've had adult patients who are just like, I'm so tired of going out to eat with my friends, and they say, hey, do you want a bite of this cheesecake? And they're like, I don't know. I don't know what's in it, right? So I'm just too nervous to try it. So, and again, it's not like for every patient because there's risks associated, and also it's, as of what we know right now, it's probably a lifetime. They have to have a little piece of that nut every day.
Yeah.
But I still think it's so cool that we just have another option rather than avoiding an EpiPen. So.
Yeah. Well, that's awesome. Talking about stories, we always like to kind of wrap up with story time. So have you come up with, or have you had any fun, entertaining, heartfelt, whatever you've got, a good, entertaining patient story?
Oh, man. It's so hard to actually pinpoint those because I truly love people so much that every patient, I'm like, I love that patient.
Yeah.
Everything feels entertaining and fun. I think one that has nothing to do with allergy.
That's okay.
But this patient came in late, like very late, like probably 30 minutes for their appointment. And they were like, well, you're 30 minutes late. Did you know appointment this time? And it was a mom who had brought her like 18-year-old son. And she was like, well, nobody told me I had to be on time. And I just thought that was the most hilarious response. I'm like, how have you got through your life not knowing that you have to be places on time? Anyways, that's nothing to do with allergy, but that one always sticks out as like, we just quote that sometimes at our clinic, like, well, nobody told me I had to be on time. Yeah.
What's time?
What is time?
I thought it was a suggestion.
But no, some
That's
of my
funny.
patients that have been probably like the most like changing, or probably like my young patients, like even a few of my really bad allergic asthma patients who are like little, like 6 and 7, and they'll be like, I'm so glad I'm on my allergy shots because now I can play outside, or this has changed my life. And they're little and they have all this like what foresight from like a 7-year-old just to get a shot in their arm, but they're happy to do it.
They shouldn't have to be worried about that for you to be able to make a difference
they can't
there.
breathe and their eyes hurt and they can't pet their dog or whatever their reason is, right? So I feel like it gives me like a lot of, I don't know, joy from my job.
A lot of happy patients, I imagine.
Yeah, a lot of happy patients. That's what I think. I mean, we definitely, like I said, we deal with anaphylaxis. So it's not that scary because we have epinephrine, which is such an amazing medication. But it isn't super fun when a patient has symptoms of anaphylaxis. You like listen to them, they're wheezing, they're flushed, they're hiving, their like throat feels funny, they have like abdominal cramping or vomiting, right? And their first epinephrine dose isn't like going so well, right?
Yeah.
You're like, now we're kind of thinking like, do we need to call EMS or whatever? But those are pretty far and few between, so it's not overly scary, and we have, like I said, good medicines. So
have you ever seen an EpiPen discharge?
Like in slow mo?
Yeah,
like
have you seen it before?
Mm-hmm.
I used to. I don't know if I probably shouldn't admit to this, but in a prior job, I used to have to cycle through our medications when they would expire, and we'd have EpiPens available to us. And when they'd expire, it was just throwing the biohazard. But I was just curious. What happens here? Those things are violent.
Yeah, they are They're power. And
like 18 gauge needles. They're huge needles, and it comes out like a fire hose. I cannot imagine going through that. It's gotta be terrible.
I actually had to give one to my husband once, and I was like, it's the nurses usually and stuff who actually administer this. So I was just like, well, swing, right? Swing the thigh. He's like, Jennica, you like bruised me. And I'm like, well, I think it's the med. It wasn't me.
That's
wild. The 18 gauge needle.
I never even thought about that.
Yeah, I fired one off. It was aggressive.
Now I want to do that with some expired supply.
Yeah. Anyway, well, Jennica, this has been awesome. Thanks for taking the time to come hang out with us. Let us learn a little bit about what you're doing.
Appreciate
Tyler,
it.
what do you think? What did you learn today?
Man, I've been impressed. I think this world is...
What did you soak in all that time?
I am just fascinated. I think I've walked away with newfound knowledge of when a person describes to me an allergy or I see an allergy list. It's like kind of breaking it down of what's a true allergy versus a hypersensitivity. I'm no longer going to give Kenalog shots. I'm going to tell that guy, hey, you got to go see the allergist.
That's right. Send him our way.
No, but it's been great. I think it's been just eye-opening to see, and what a valuable resource in the community to have somebody that can go get information on how they can change their life, because I've experienced allergies myself, and it can be daunting, like trying to get through it. So just to know that there are people out there supporting these kids and adults is super helpful. So super valuable. Thanks for coming on the show today.
Yeah, I
really
enjoyed
appreciate it.
How would somebody connect with you if they wanted to reach out and maybe had some questions or wanted to connect some way?
Yeah, at the Salt Lake Clinic, you can just go onto Intermountain, find a provider. They can search my name, Jennica Van Blerkom, or they can look by location. Like I said, there's allergists kind of spotted around the valley. So
Perfect. Are you into the social media world?
not with Allergy, but yes,
Okay,
I don't think
Not
I have an
professionally.
Intermountain.
Okay,
Yes.
okay.
I thought about it. I thought about doing some TikTok allergy videos.
That would be
for-
cool. You
for a
should
hot
put it out there.
second, Yes.
Yeah, you should definitely do that.
I've thought about it. We'll see.
It's
'Cause there's
useful information. It's
Discharge
good
an
for
EpiPen.
Yeah, discharge. That's
In slow motion.
it's actually a really
New
great
video.
opening
We should-
video. Yeah, I love
Yes,
it.
That would be killer. That would be awesome. Okay, well, with our clinic, people can find us online. We are involved professionally through the social medias. On Instagram, it's Summit Brain, Spine, and Orthopedics. On YouTube, it's Summit Medical Institute. And then we always like to see people in person Tuesday mornings at the Holy Cross Mountain Point Hospital in Lehigh for our interdisciplinary case rounds discussions, 7 a.m. on Tuesdays. We'll see you there. We appreciate Jennica coming with us. We always appreciate our production team, Dallin and Amelia, for putting things together behind the scenes. I always appreciate Tyler sitting next to me, hanging out, soaking it all in.
Soaking it in.
And we appreciate anybody that's listening. So leave us a comment, leave us a review, tell us how we're doing and what we need to do differently. Yeah?
Yeah.
Love it. Okay.
Love it.
I
Outro.
appreciate everyone that's involved. We look forward to keeping this thing rolling. We'll see you around next time for the Many Minds podcast, where we are using many minds to collaborate for better patient outcomes.